I am your host, Carrie Scollin, giving us different perspectives on where we are and where we want to go on our journey. Thanks for being here, and I look forward to spending some time with you. Hello, everyone. Welcome to another session of the Founder Series. I'm your host, Carrie Scollin, and I have got an incredible guest with me today. Her name is Dr. Tracy Rodgers. You have probably heard me talk about her, share her. I think her expertise in this area is beyond any I've ever seen. Her genuine, authentic intention to help women is absolutely obvious to me when I speak with her. So Dr. Tracy, thank you so much for being here. I think there's going to be a lot of people that have a lot of questions, and we're going to try and go over some of the most general ones. Yeah, some of the most general ones, so that you don't have to answer 1,000. We might be able to reach 1,000.
Exactly.
In one conversation. So
we've talked about, and thank you for all of that. Like, I really appreciate being here, and I appreciate everything that you do for women too. I've been a part of your retreats, and not only has it been a really good experience to come and share my knowledge, but the 2 times I've come, I've walked away with relationships, with education, with my own learning. So it's been an incredible thing to be a part of that, which, like, women in community is so great.
It is.
And we don't get enough of that, I think, at times, right?
Oh, so, yeah.
Menopause is a massive, massive, massive topic. So it's hard to hit all of the highlights in one conversation, but we'll kind of do an overview of, like, why are we even talking about it? What's so important about it? And how do women get care? Like, my goal is, it has always struck me as really strange that menopause is something that if you live to see your 50s, which most of us do, 100% of us go through this transition. 100%. So we spend all this time in medical school and training learning about things that have, like, 10% of the population get, or 5% of the population get, but menopause is largely ignored, but it affects every single woman. And so the medical sort of dismissal of it is one thing, but I'm often astonished that most of us don't know what's coming. We don't know enough about our own bodies. We don't know what to expect. So when it happens, it almost like hits us like a freight train, like, what is happening to my body? And we're super confused about it because nobody prepares you. And then when you go online and you start looking up menopause, well, cue the confusion, because there's mixed messages and confusing things about risk. And at the end of it, I think it leaves women more confused than when they started a lot of the time.
That's absolutely where I was, for sure. There was so much information out there. And I know it's not a one done. I know there can't be just, this is what you do, follow these things, and, away you go. I know that's not the case. But to try and decipher, it was just, my head was exploding. And then I just stopped. Because I'm like, okay, I'll just deal with this. But for you, Tracy, I know when you talked about the community and women getting together, I think one of the things that I love that you bring is your own experience in it. And I think when we are learning from somebody, we want somebody who knows what they're doing, right? Somebody who has expertise in that area, but also somebody who's gone through and can understand what we're
lived experience of it.
And I think for you, I love every time that we've been able to share you with an audience, you have a hat of, it's me, I'm Tracy, I'm human, I'm a mom, I'm a woman.
I'm in the swamp with you.
Yes, you were going through the trenches with us. And then you have to go, okay. And so that's part of my story. And now, because story is so important, now I'm going to put on the Dr. Tracy hat.
And here's the medicine side of it.
And here's the medicine side. So I really love how you combine both. And I think it's really, really important that women don't just focus on the one thing. There's a lot more going on than just.
Oh, I always say menopause does not happen in a bubble. And the issue is ignoring it as an issue for women harms men, harms children, harms the economy. So we don't go through menopause alone. Our partners go through it with us. Our kids go through it with us. Our coworkers. It affects everybody around us. So, and women leave the workforce. They don't take that promotion, or they go down to part-time. And all of that is a big detriment to not just the women, but to the people who love and care about them as well.
Yeah.
So that's the other thing. It doesn't happen in isolation. It's not just happening to you.
Right.
Right.
And the preventative, like, yes, I would love to go and do everything to prevent it from happening. But like you said at the beginning, we can't prevent this, but
it is inevitable.
It is going to happen whether we wanted to, or we cannot avoid it. So I think what you're doing on the education end of it is, here's what may happen.
Exactly.
It's not going to be the same for everybody, but this is what you help women with, right? I mean, this is, if you have time.
And also like trying to broaden the lens through which we look at menopause. Because if you think about medicine, we chop up the human body into all of its individual parts and farm that out to specialists and subspecialists. And you have to, because it's complicated. But the problem is you can lose sight of the interconnectedness of all of it. And menopause is one of those unique areas where it doesn't happen to one body system. It's an entire body process that affects every system in your body. And not only that, it's also a time when women start to come home to themselves, because I sort of think that we all kind of go around holding a beach ball underwater as women, and we're nurturers, we're caregivers, so we're doing all of our various jobs, and we hold that beach ball underwater and like, don't worry about me, let's take care of you. And we manage it. Like, we're not always killing it, but we're doing it. And then menopause hits and you're not sleeping and you're weepy or you're ragey or you're all of those symptoms, and that beach ball starts to sort of come up in your face. And so it's also a really significant life transition where we're confronting aging, we're confronting the loss of our fertility, we're confronting all these symptoms, and you start to say, is this where I want my life to be? Like, do I want to keep saying yes when I really mean no? And divorce rates go up in the 40s, and it's a really huge life transition, and it often coincides with your kids going through puberty, or your parents going in homes, or your parents dying, or all kinds of other life events that tend to come up at midlife. And so if you can't just zoom in on, are you having hot flashes, and think that that's the whole story. Like it's you have to put it all together, and this, like, chopping off our heads, like the mental health symptoms, we'll go see a counselor, and we'll deal with your body. Like, I like to joke that most gynecologists are like uterus, tubes, vagina, vulva, ovaries. Breasts, nope, that's general surgery. And like, there's an imaginary line between your vagina and your anus, and that's gynecology, that's general surgery, and near the tween shall meet.
And that's it.
But like, we kind of do that, right?
Right.
But I think menopause is a time when we've got to look at the whole system and start to take care of our bodies and what keeps us healthy. We look at it through a sickness lens. So if you intervene and add hormones, who gets what diseases? And it's population based. But the assumption there is that menopause is the default, like the normal, the natural, therefore the safe. And we only make risk when we add interventions. So go on hormones, don't go on hormones.
Right.
But that's actually not the comparison. You've got to talk about the risks of hormone replacement therapy with the risks of untreated menopause, which is a lot of the things we just talked about, but it's also our risk of cardiovascular disease, type 2 diabetes, osteoporosis, cognitive decline, all increase sharply at menopause.
Yeah.
And so you have like sleep deprivation increases your risk of obesity, cancer, cognitive decline.
Yeah.
So if you take HRT and you're sleeping through the night, surely that lowers your risks of other problems.
Yeah.
That likely offsets any risk from hormone replacement. So risk has to be put in context with the risk of doing nothing, which for menopause is significant for a lot of women.
Yeah.
And we often don't think of it that way.
That's very true. I mean, when I first went on HRT, it was because of you, and no doubt life-changing, but I got my prescription filled, and it wasn't through you, it was through my other doctor, but and it sat on my counter for like 2 months. I'm like, I don't know, I'm kind of scared.
I don't know.
I don't know what's gonna happen.
Like, where does that come from?
I don't know. And then it was like, okay, I'm just gonna try it for a month. I'm gonna see how I feel, give it a try. And like 3 days later, I got up and I got out of bed. I'm like, oh my God.
Why did I leave that on my dresser
what is happening?
for 2 months?
Yeah. I'm like, I just didn't feel the soreness or the whatever it was when I got out of bed. I'm like, okay, if I'm feeling this, there's probably a lot of other women who are out there, like you said, trying to assess the risk, but they're assessing something that is
they
old,
don't understand.
And it's old. It's an old, what do they call it? An old research, whatever it was. It was based on something. It's basically
based on poor reporting of poorly interpreted research that was not even asking the right question in the first place.
Yes. So that's where a lot of us got
that's the whole thing. But you just brought up a super important point that needs a little highlighting. And that's the fact, like I say to my patients all the time, unless you have an estrogen dependent cancer, or you have a blood clot, or you have significant cardiovascular disease. Like there are things that liver disease, there are things some women shouldn't take hormones.
Right.
But that list is really small. So most women are safe to take hormone replacement therapy as a trial. So provided you're in that group where there's no contraindications.
Right.
And what I say to people is like, okay, but you don't know what hormones can do for you. So what I recommend is like nothing bad is going to happen in a month. Like the short-term risk of estrogen is blood clots. So oral estrogen slightly increases your risk of blood clots, but less than birth control pills and way less than pregnancy. So none of us say, I'm not going to have a baby in case I get a blood clot, unless you have a clotting history.
Right.
Nobody thinks about that. They just think that's a risk.
Yeah.
But a lot of people with hormones are worried about that. And so it's way lower risk than those things. But transdermal estrogen doesn't increase your blood's risk of clotting. So 3 or 4 weeks of exposure to hormone isn't going to do you any harm. So most women, what I say is like, why don't you just try it?
Try it.
Like if you don't know, just try it. And if you, then you can go, that was me without hormones. This is me with hormones. And if you're like, oh my God, I feel like my old self, I can sleep, I like my husband again, like I have energy.
Yeah.
Then you put the risks in context with how it makes you feel and your improved quality of life. Because women who are exhausted, who don't sleep, every other symptom is exacerbated. The mental health symptoms, the joint pain, the irritability, all of it gets, and you're less likely to exercise. You're more likely to eat carbs. You're more likely to drink more alcohol, be sedentary because you feel like a dish rag.
Yeah.
We don't measure those risks in a study. Like that's really hard stuff to tease out.
Right.
But so many women have told me when they get their hormones and they're sleeping, their brain is clearer. They've got more energy. They just feel so much better overall that if there is a small increased risk in the long run, it's like, yeah, but I can't go back to living like that.
Absolutely.
Like that's way riskier than this.
Yeah. And you talk a lot about the quality of life, right?
Mm-hmm.
I mean,
because quality of life is huge. It's huge.
Yes.
Yeah.
And there's a lot of people that are suffering when they may not have to be. Right?
No, and there's an entire generation of women after the Women's Health Initiative that didn't get offered HRT at all, or were told you can't have it.
Yeah.
Which which is another point that I don't want to forget. And I need to get this one in there too. That kind of paternalism and like, there, dear, you can't have this, doesn't exist in a lot of areas of medicine.
Mm.
Like, if you think about it, even, okay, let's assume that the Women's Health Initiative, the risk of breast cancer in that trial is applicable to all women who take hormones, which it isn't, not by a long mile.
Mhm.
They weren't on real progesterone. It was Provera, which is a progestin. It was much older women. And so that doesn't apply to women in their 40s and 50s taking hormones. But let's just say it did.
Yeah.
And so what that study showed was after a few years of use, there was one additional breast cancer per 1,000 patients. That is a very small increased risk.
Mhm.
And if you think about the risks of all of the other things, like heart disease being the number one killer of women and quality of life and all of those things, most women are very accepting of that small increased risk.
Right.
But they are told that, well, no, you can't have it. If you look at like a total hip joint replacement, within the first 10 days after surgery, I think your risk of a blood clot is 13%. And these people have lots of medical comorbidities that are risky for anesthesia. But you can choose to do that.
Yeah.
You can choose to get a knee replacement. You can choose to take Viagra. Viagra has lots of risks. SSRIs carry a risk of suicide, but we prescribe those things and do those things all the time. Like,
Yeah.
you take a risk to get in your car to go see your doctor. So
Yes.
why do we not give women the space and the autonomy to decide what risks are acceptable for them,
Yes.
for how they can feel?
Yeah.
And one of the big obstacles in that stream is the clinical guidelines indication for hormones. It's mostly like hot flashes, osteoporosis. So you go to your doctor, do you have hot flashes? No, nothing wrong with your hormones, then you're okay. Right?
Yep.
And
Yep.
you're not supposed to prescribe it for mental health symptoms. That says go to the psychiatric meds. But why are we treating hormone deficiency with SSRIs
Right.
if the cause is hormone imbalance? We skipped a step there.
Yeah.
But that's kind of how it goes. So
Mhm.
if you think about it, it's no different than any other aspect of women's lives, because most of what I did as an OBGYN wasn't managing pathology. A lot of it was just managing the normal things that go along with
Right.
being female,
Female.
right?
Yes.
And you know, it's I think there's too much you can or you can't. Our job should be to explain the risks and to the best of our knowledge, because
Right.
we don't have a giant population-based study with real progesterone and 17 beta estradiol. It was horse estrogen and progestin. And we don't have the same study. So those,
Yeah.
like, it's apples and
base it on-
oranges, guys.
Yeah.
No. So your research is only as good as the questions you're asking.
Yes.
So if you're going to put everything on the altar of research and what are the approved indications, we're going to be waiting 50 years for,
Right.
you know, these things to be approved. So,
Yeah.
you know, I tell my patients, HRT is not indicated for mental health symptoms in the guidelines necessarily. However, your mental health symptoms are caused by your hormone deficiency. And if you take progesterone and everything gets better, then there's your answer.
Yeah.
Like, it's kind of like that. Is this my hormones? Well,
Right.
there is no test to see if your joint pain is your hormones.
Right.
You take hormones. If your joint pain completely resolves, then it was likely related.
Right.
And if you have persistent joint pain, you've got to look into other causes.
Right.
Menopause is kind of like pregnancy care. You can blame anything on it. Well, you're in menopause. Well, you're getting old. Right?
Yes. And that happens, doesn't it?
Yeah, it
That
totally
absolutely
does.
happens. So you
Yeah.
were talking about one of the biggest things that I heard you say there then was, wrapping it up into like a small little thing, is you need to assess the risk across the board,
Mhm.
individually for you, but make sure you're getting make sure what you're reading and the advice you're getting is from somebody who's actually
Exactly.
knows
Yeah.
what they're talking about.
Yeah.
That being said, the access to expertise in that field is very hard. I mean,
Yeah.
there's wait lists of 2 years. for some
Yeah,
people.
it totally is. Oh my God,
So-
if I had to wait 2 years for hormones, I don't know if I'd be here. It was so bad.
Yeah, and you went through
that's
this
not okay.
at pretty young age, didn't you?
I did.
Comparably to what the
Oh my God,
normal
I
range
went
is.
from any woman who's listening to this, who relates to this, I feel you, sister. I went from postpartum to perimenopause. It was like I never recovered from having my second baby. And I was like, what is wrong with me? And full disclosure, if you're out there feeling confused about your body, I am a gynecologist. I had no idea I was in perimenopause. I blamed anything and everything. It's my husband, it's my job, it's my kids, it's my life. I'm too busy, I'm too stressed. If I could just slow down. I didn't clue in. And when I went to my GP, I, of course, got offered antidepressants. I was so desperate. She didn't want to talk about hormones. You're too young. And I wasn't too young. I was in my early 40s, like it, and I didn't even know how to advocate for myself because I didn't really understand what I was going through. Mm-hmm. And when I went on hormones, I was like, my joint pain's gone. Nobody told me that was a menopause thing. Like,
yep, me too. No idea.
What kind of training are we getting? And then I realized we actually don't get any menopause training. There is no menopause course when I was in residency. It was if you had a clinic day and you happen to do it with Dr. So-and-so, you might see 3 menopause patients with her. And maybe it was at Journal Club or Grand Round, someone did a talk, but it wasn't like, this is your menopause course.
Right.
Which is crazy. We spent 5 years learning to do obstetrics. Not all women are going to have a baby.
Right.
But all women are going to go through menopause. Yes. So why are we not training better? So then I went around saying to everyone that I worked with, like, do you think you're doing a good job of treating menopause? Because, like, you're not. Yeah. I'm just telling you, like, we're not trained right. I can't believe what is happening. And so it kind of made me like, and I've been listening to women for years about it and thinking, what I learned and what these women are telling, this doesn't match.
Right.
And then when I went through it myself, I was like, bing, bing, bing. And I started to really get passionate about how we treat women's hormone imbalance, especially in the lens of mental health. PMS, PMDD, postpartum, perimenopause. All of those areas are punctuated by a prevalence of mental health symptoms. And there isn't a push to be treating those with hormone. And, when you look at statistics, that women's risk of suicide goes up multifold between the ages of 45 and 55. This is something we're not taking seriously enough. And so I started to realize, like, I've got to change the way I do things. The guidelines are kind of done, like, I was sort of trained with a one-size-fits-all approach. And come on, do you know 2 women with the same birth story?
Yeah.
None of us have the same menopause story. It's like, as individuals, our fingerprints. Yeah. So there isn't a one size fits all, but it's also not just to HRT or to not HRT. Right. There's a lot more to it than that as well. So a lot of people think, like, my practice now is 100% focused on hormone management. And a lot of people think, like, you have to have significant symptoms, or you've got to be, like, at a certain age, or you've got, to justify seeing a specialist. And that's not it. Like, just giving people information. And, like, women who would say, oh, well, I don't want to take HRT, so what's the point in seeing her? Because that's all she's going to offer me. And you don't have to want hormone replacement therapy to benefit from seeing someone who does menopause, because you might not want HRT. And at the end of our discussion, you may still not want HRT, but at least you are making a much more informed decision when you've talked to somebody about what the jigs and the reels of it all are. And plus, what are your other options? And what are the risks to your body from estrogen deficiency in the long run? A lot of women don't know that if you break your hip from an osteoporotic fracture when you're elderly, the mortality of that is 50%. A lot of women don't know that you're way more likely to die of heart disease than you are of breast cancer. That's a mystery to a lot of women. And people think men die more of heart disease than women. No, we're dying at 4 times the rate of men now, because most cardiovascular research has been done on men.
Men.
And women's heart disease is different. Surprise, we're different from men. Who'd have thought, right?
Yeah.
So we've got a lot of catching up to do in that area.
Yeah.
And you're starting to see like more and more people talk about it. Like I just watched a podcast with Lisa Mosconi, who's an Alzheimer's prevention researcher. And she talked a lot about imaging the brain at different phases in hormone cycles and the impact of estrogen deficiency on the brain. And I was like, wow, I didn't understand evidence. The physiology. Yeah, more it's evidence. Just, yeah. And that's what I mean. Like if we look at it all through the clinical guidelines for physicians, it's very myopic. Like there's a whole lot more to this than that. And women deserve to have this listened to and taken seriously and treated. I think that's not just about hormones.
We want to be heard. Mm-hmm. Right? I think that's one of the biggest things. Also, I want to make sure that we get in here that you have done your research, you know what you're talking about, you back up a lot of things from some of these, but you also say that some of this comes from your own experience and from your patient's experience. So you're gathering more information that, yes, you may not have something that has the evidence to prove it, but you've talked to enough women to know we're onto something here.
And a classic example of that is testosterone.
Yeah.
Like there isn't a lot of evidence around testosterone replacement for women. Mm-hmm. And if you look at the literature, it almost seems like testosterone is sort of not considered particularly important. But as far as I understand, there is no pharmaceutical company that makes testosterone in a female dose, and you can't patent testosterone. So if there is no money to be made, that shouldn't surprise you that there's no research. It's not going to happen.
Right.
However, testosterone is looked at for low libido. But if you talk to women who take testosterone, and you talk to other practitioners who prescribe testosterone, we see something different that doesn't pan out when you try to find it in the literature. And that's improvement in mental clarity. Women notice that they can hold on to their muscle better. Like a lot of women I talk to, these fit, active women, they start to notice that they're losing muscle and gaining fat. And they're working really hard, and they're starting to lose their motivation to exercise because they don't feel the benefit.
Right.
It's exhausting. It takes longer to recover, and they don't have a lot of drive. Like I sort of describe testosterone deficiency as, well, I'd like to go do the thing, but nah, like nah.
Oh, like that sounds like me. Know? I think I need testosterone.
Yeah, and it doesn't always work. It's not magic. Like you don't take testosterone and go, I'm going to take on the world. Like if you do, you have too much and you should see a doctor. Right. But it can be so helpful for some women.
Yeah.
So I don't withhold testosterone treatment. I just say there's not a lot of evidence to back it up. And here's what I know about it.
Yeah.
And again, if you don't notice improvement, don't take it.
Exactly.
But if it makes a big difference for you, then take it with this understanding. And most women are like, it makes no sense that it's not in the guidelines. It makes no sense that there's no studies. Of course it makes no sense, but that's the world we live in.
Yes.
So yes, I do things that are outside the box. I treat mental health symptoms with hormones, and I've been treating PMS and PMDD with hormones for most of my career with pretty decent success.
Yeah.
And I still maintain PMDD, which is premenstrual dysphoric disorder, does not belong in the DSM for psychiatric conditions. It's a condition of hormonal imbalance. It only happens at one part of your menstrual cycle. How are we saying this is a primary psychiatric problem?
Yeah.
It's not, but we don't have enough curiosity about the biology of mental health. It's what drugs fix what symptoms.
Right.
And yes, it sounds critical, but like a diagnosis of depression is a symptom. It isn't a thing. Like it's the name of the condition is the symptom.
Right.
So, but what causes depression, and is all depression the same? And Are we depressed because we're hormone deficient? We haven't slept in a month.
Right.
And if you took some progesterone and slept, you might actually not feel depressed anymore. But we put those women on SSRIs. And the problem with that in menopause is they make you gain weight and they decrease your libido. Hello, we're already all experiencing that.
Yeah.
And
we do not need help in that area.
no, we don't.
Fine.
And they don't have the side benefits that hormone replacement therapy does for women.
Right.
So, you know, like it's all this part and parcel of trying to contextualize it between what we're supposed to be doing and what actually listening and talking to women tells you they need.
Yes.
And I guarantee you, like, not to be against men, but I guarantee you, if men turned 50 and lost their sexual function and their sexual drive, and they cried at the dime and they sweat the bed every night and they couldn't control their tempers, they would be treated like it would be considered significant. So, like I tell women, if your doctor says you can't have hormones until you haven't had a period for a year, follow it up with, do you prescribe Viagra until there's been no erection for a year? And if your doctor says, no, that's ridiculous, then you say, well, why would you treat women differently than you treat men? Do men actually have to have bad erectile dysfunction to get that? Or can they just say, hey, doc, I want my boner to be a bit better, and they get it? Yeah, that's the way it is. P.S. Those drugs have risks too. Like, oh my God, right? And so
great example. That is a great example. I mean, really,
it is.
When you bring it back down to that, that's so true. That's so true.
So, you know, I think we need to get back to your access question, because I tend to go like way off on a tangent.
Oh, right. Yes. So
circle back to it, but
and referrals.
Access is challenging.
I mean,
the truth is, you probably get a different approach depending on which gynecologist you see or which GP you see. Right. Like, you could probably go to 10 different doctors and get 10 different stories about HRT. And that's just the way it's going to be for something that's as complicated as menopause and hormones. However, so if you have a primary care provider and your primary care provider is comfortable prescribing hormones and you're comfortable with that, perfect. And then if you run into issues where it's trouble getting the right dose, then they're willing to refer you. That's the easiest stream of care. But if you have a primary practitioner who won't treat menopause or doesn't know how to treat menopause, and by the way, that's not your GP's fault, that's a system problem. Right. But also, if your family doctor is really curious about menopause, they have to go out of their way to learn about it, and most of them don't. They are trying to be a cardiologist, a dermatologist, and not like they have to do everything. So we all can't expect them to know our own field brilliantly. That's just unrealistic. Yeah. But if they don't know and they say, well, I'll send you to someone who does, great. But if they don't know and they say no to a referral, which happens a lot, then you're in a little bit of a quandary. Or if you do not have a primary care practitioner, because in order to see a gynecologist or somebody like me, the system is set up that you need a referral from a GP or from a nurse practitioner. Unfortunately, we cannot take referrals from naturopaths. So that's a bit of an issue. So in the case where you have a GP or a primary practitioner who does not wish to refer you, I try to give people the physician's aspect on this as well, because sometimes it's just not your physician being stubborn. There's actually a lot of politics behind that sometimes, because I'm a specialist and I've been in that specialist GP world for a lot of years. And a lot of specialists give GPs a lot of blowback for so-called stupid referrals or dumb referrals. Yeah. And I think GPs, like we have a saying in medicine that shit rolls downhill. So I think a lot of GPs don't want to send hormone replacement referrals to a specialist because you've got a really long wait list and it's going to take time and maybe you don't think is important, or I don't want them to think I don't know how to manage this, or to write me back and go, I'm not seeing that. Like, what's wrong with you? Right. So, and doctors have this inherent problem with not knowing or being wrong, because that's beaten out of us in medical school. Like, you're humiliated if you're wrong. So, you know, that creates its own set of problems. Right. So, you know, how you get around that is I would ask my doctor, can you send the referral anyway? And most specialists triage their referrals. So if I read a referral that's outside my scope of practice, or I think I can help this person, I send it back to the GP and say, I'm not going to see this person, but maybe you should consider sending them here.
Right.
And that's up to me. It's not up to a family doctor to decide what I will and won't see.
Yes.
Like I can sort of decide that. And I don't think I've had very many instances in my 20-something year career where I've been in a room with a patient and thought, this is a waste of my time. Right. And it's almost never that way.
Yeah.
So you can say to your doctor, like, can you send it anyway? And let the specialist decide if they'll see me. Yeah. And I think that is a hard thing to say no to. Right. But if you're still getting in that spot, then you're in the same position as somebody who doesn't have a family doctor.
Right.
So then you either go to a walk-in clinic and beg, or you go online and you book with like a medical online service like TELUS, and they will refer you. In Comox Courtney, there's also a self-referral women's clinic called Rosewall Women's Clinic. Mm-hmm. They have a website. They will see you for like pap smears, IUD insertions, STI, like sexually transmitted screening, and that kind of stuff. And they will send referrals for menopause management and perimenopause management. That's another great resource for women in our community as well. And I believe there's 3 female GPs who are doing that.
Wow.
And one of them is Dr. Sarah Olson. She was in my office for a while they were setting up their clinic. Mm-hmm. She does tons of IUDs, and she's more than happy to facilitate people getting hormone care as far as I understand. So that's another place people can go. Yeah. But unfortunately, the only self-referral or self-pay options are private. And I completely understand why a lot of hormone providers are doing private medicine. Yeah. I'm considering it myself because a lot of what we end up doing is under the umbrella of complementary and alternative medicine, because it's not represented in the guidelines and in what we're supposed to be doing. Yeah. And it gives you the fortunate thing of a bit more time and to be able to provide more follow-up, because that's one of my issues in my practice. I don't have enough time to spend with the patient that I want. Right. Because if I spent as much time as I would like with each referral, I could say, would you like fries with that? And I would make the same amount of money, and I wouldn't have to give anybody medical advice. Yes. So,
sad but true.
We don't get paid to counsel. We don't get paid for preventative medicine because it's a sick lens. Like, we're doing sick care. And I actually want to do well care. And they're very different. Yeah. Yes. Yeah. And menopause actually should be through the lens of well care. Yeah. What we should be trying to do is take women at a time when they have no choice but pay attention to their bodies and what's happening to them, and actually set the stage for healthy living into your 40s, 50s, and 60s. Yeah. I don't see a time in women's lives when they're more open and receptive to self-care and lifestyle change as when they're in menopause, because they don't have a choice. Absolutely. They feel so bad that they're willing to do just about anything to feel better. Yes. And we need to capitalize on that so that we're actually creating really healthy, active, happy 70 and 80-year-olds, right?
But and those conversations need to start earlier, right? Though, but they may not be ready to engage until they're actually starting to feel the symptom. Which so I understand what you're saying there. That's the time where they're going to listen, because they have no choice, really. If we could get it a little bit sooner.
Oh, yeah. Like most women
before they get into
it. My God. I mean, I would like to know how many years most of us suffer before we get help. Exactly. Because it's like this slow change. Exactly. Like slow. And so you kind of can go, new normal, new normal, new normal. New normal. Oh my God, wait a minute. I've been feeling like ass for 6 months.
I think that's more likely. That's what mine would have been. I didn't really notice. And then all of a sudden it's like, what? But I wasn't.
Yeah, wait a minute. My previous level of function is so much higher than this. Yeah. But you know how I know? I look back at what I did in my 30s and think, I could never do that now.
How
I
did I
don't know
do
how I did. I don't know how I did that.
Yeah.
Like,
Same.
and I don't know why I wanted to do that.
Right.
I care more about me now and like what
Yes.
I want, what makes me happy,
Oh.
what fulfills me in life. But back then I was like a energizer bunny and I was mostly doing things for other people.
Yeah.
You know, and so I'd like to have the energy I had then, but I don't want the attitude. Like
That's true.
I like this new space that we can settle in.
Me
Like
too.
on the show
Me too.
Fleabag, there's, if you YouTube the menopause expert from excerpt from the show Fleabag.
Okay.
My favorite part she says is, Fleabag goes, but I thought it was horrendous. And she goes, oh yes, it's horrendous and then it's glorious. Like first it's horrendous, but then it's glorious. And I'm like, yes. That is so true.
I like that.
So true.
It is
like
so
I kind of describe it as you have to go through the dark forest. You got to go through the shit pile. It's a bit of a shit show. It's going to happen. Mm-hmm. And that's really horrendous and challenging and difficult for so many women.
Yes.
However, it's not all bad because out the other side of it, there's a transformative process that can happen through this if you let it. I know so many women who come home to themselves for the very first time through this process and let go of a lot of old traumas or confront and deal with the things that are coming up because they want to be whole. And menopause is such an invitation for that if you'll allow it, right? And if that's it took me a while to see it, but
that's what we have to start identifying it with rather than the horrible things that are attached to menopause. And there are some, but there can be others too.
Yeah, and when you talk about the horrible things, and like I like to talk about mental health a lot, but it's a double-edged sword because on the one hand, if you talk about it really honestly, like the stuff that goes on inside our heads, you run the risk of making everybody think women in their 40s and 50s are batshit crazy.
Right. Which they're not.
And you can't trust women in their 40s.
Right.
However, it's also that's not all there is to it, but we don't have to feel that way.
Yeah.
There's treatment for that so that we can actually function better.
Yes.
So I think that's why there's been a lot of silence and shame around menopause is because if you really tell people what we go through, then people think women in their 40s and 50s are more useless than they already do. And that's not the case at all. It's, so we do have to you got to be real and honest about the negative stuff because otherwise women feel alone and they don't want to say it out loud. And there's so much shame, but we also have to make sure that we say but it's beautiful and it's transformative and your body's calling you home. And it's an opportunity to look at your relationship to yourself and repair and heal that. Because in my experience, at least 90% of us have a bit of a messed up relationship with self.
Yes.
I know I do.
100%. We've talked about that lots. Yeah, we have. And this is why I really, this may not be popular opinion. It doesn't really matter, but I would love to see you go private because I think you also have a lot more to offer as a rounded treatment. Treatment might not be the right word, but you know what I mean? You've got the expertise and the ability to help them with figuring out the HRT if that's what they choose, or if they don't choose that, what are some other alternatives? And I think that's what I love so much about you sharing your story, that I know that you've gone through it. You can't do that in a setting how it's set up right now. I can totally see why you want to go the private route because you can do more good there.
Yeah, I have more to offer than what I can do in an MSP appointment.
I mean,
and so, and how I've been really struggling with this because when I only do menopause now, how can I give well-rounded, good care in this space that MSP sort of allows us to do it? And it's damn near impossible.
Yeah.
So really what I'm doing in my practice, I've kind of come up with a menopause care plan, and I've divided it into what I call outside work and inside work.
Yeah.
And it's sort of based on, I heard Wayne Dyer tell a story about if you're in your living room and the lights go out and you drop your keys and you can't find them and you see there's a street light on outside, so you think I'll go look out there, and your neighbor comes and helps you and you can't find your keys and you're like, well, I dropped them in the living room. And your neighbor's like, what? And you go, well, there's no sense looking in there when there's light out here. Like, that sounds so stupid. But when we feel like something is wrong inside of us and we instantly go, what is out there that's causing it? And where's the fix? Like, somebody give me something to fix this.
Yes.
You're going to be led astray a lot. It's like that old horror movie where the cops are like, the call is coming from inside the house. The call is coming from inside the house.
Yes.
So there's both. So I do outside work with you. So it's basically, what are your risk factors for heart disease, osteoporosis, breast cancer, your health, your medical and surgical history, your age, your hormone context, your symptoms. Do you have iron deficiency, B12? Do you need a pap smear? Do you need a mammogram? Like, all of those sort of things that medicine does for you. And then, are you a candidate, or do you want hormone replacement therapy? That's kind of the outside work.
Right.
We don't do inside work in medicine. And I think it's absolutely critical to the process. So I describe the inside work as what the foundation is for health and well-being, because it's not, hormones don't fix everything.
Right.
So it's fuel, movement, and rest. And so if you don't sleep well and you haven't exercised in a decade and you have a poor diet, do you think taking hormones is going to fix all of your symptoms? Right. No, it is not. Like, you have to lift your end of the sofa.
Yes.
So that foundation is so critical to health. So when lots of doctors can say, well, you should exercise more, it's better than antidepressants. But why don't we do those things for ourselves? So what is the boulder in the stream to like, everybody knows smoking is bad for you. Everybody knows exercise is good for you. Everybody knows processed food will make you sick and you should eat real food. Like, even your mother told you are what you eat. Like, this isn't rocket science.
Yes.
But yet we do not. So where is that boulder in the stream?
Yes.
So how you start to build a stronger foundation for healthy living past menopause is you look at the relationship with yourself. And I look at that as the relationship with your mind. Most of us are so hard on ourselves and beat ourselves up and say the worst shit to ourselves in our head. Yeah. I would never say to you the stuff I say to myself. Never, ever. And if I did, I would expect you to never speak to me again. So a healthy relationship with that voice in your head, that's huge. And then how our relationship with our bodies are. You've heard me do that letter to my body. Dear body, I owe you an apology.
Yes.
I expect you to be awesome and do everything for me, but I don't give you the right fuel, rest, or movement. And sometimes I put toxic shit in there for you to deal with. And I do not compliment you. I point out everything wrong with you. I don't let anyone else compliment you. That's an abusive relationship I just described. That has been my relationship with my body my whole life. Yes. It's terrible. And then it's memory and imagination, depression, anxiety, past, future. And, if you've got one leg in the past and I'm like this because of the thing that happened back there and it determines my future, then you're on a trajectory where you believe the wake is driving the damn boat and it's not. Yes. And if you're afraid, like I told you before we started this, I have wanted to write and talk and do retreats and put myself out there for so long. And I've been incapacitated by fear, fear of criticism, fear somebody's going to say I'm stupid, like all kinds of stuff. Yeah. That's a disordered relationship with my future, my imagination, my ability to see something different for myself and then go for it, because there is no change. There's no forward motion without vulnerability, being willing to fall on your face, fail, get up and do it again. And along the way, learn your worth. That's part of the inside work. So I want to figure out a way where I can get a community of women who want to work together on inside work, because I haven't allowed myself that space yet. I'm always like, take my advice, I'm not using it. I will offer you water that I won't drink. It's
Right.
So I need to actually move from intellectualizing this to actually trying to live what I've learned is important and critical to my own
Yes.
wellness.
Yes.
But if we could do it in community some way, that would be amazing.
Massive.
So yeah, I've got lots of plans coming down the pipe, but
yes.
right now I'm just,
I know. I know
through.
you can't add anything more to your plate, but when you mentioned to me about down the road, you see a membership platform. That's building community. That is you being able to get your message to more people. And that, I think that's what one of the biggest thing is we don't have access readily to people like you. So for you, for us to take you out of that system where you can run it how with all those things that you just described, that's what we need. That's what we need. But until then, and I think people would be signing up for that membership because, like I said, they want to be part of a community with other women who are going through the same thing.
Oh, absolutely. There's
and they
so
want to
much
be heard.
Power in that.
Yes, they want to be heard by somebody who
validation.
Yes, but you have the ability to help in both ways.
Exactly.
Right.
Exactly. And creating
those.
Community is important.
Yes.
And not just a community of women who are sort of going through a shared experience together. Like the value in that is so clear.
Yeah.
But I'd also like to get a community of care providers because I have one lens, but it's not the complete picture.
Right.
So, trauma counselors, therapists, people who do acupuncture, pelvic floor physio, primary care, and art therapists, like anybody who is interested in the care of women in the transition of perimenopause and menopause. I'd like to create a community where we can let all the primary care people know, like, these are the people who actually have expertise and are interested in it.
Yes.
And I mean, ideally, we'd all work together and you could just do one-stop shopping. Like, wouldn't that be amazing?
That would be amazing.
Yeah. I mean, while I'm dreaming, I'd also like a machine that you stick on your side that tells you, you need this much estrogen today. Bing! And that would be so easy. But,
how amazing
that's just a pipe dream. It would be.
Keep that on the back burner, though.
Yeah, right. Because it takes a village. Like, I can't be all of the things menopause, but I can do my area of expertise really well.
Right.
But I'd like to pair up with other people who come through different lenses, naturopaths, people who do functional medicine, all that kind of stuff.
Yes.
And so that way people can sort of pick and choose, like, depending on what you're really struggling with, there's other people you can see to help you with that. And if we had a shared community where we actually shared information and resources and expertise, then we're all communicating. Because anybody who sees a naturopath, most of the time your experience is GP says this, naturopath says that.
Right.
They're conflicting. GP says don't listen to them. Naturopath's trying to help you, and you feel monkey in the middle.
Yes.
And neither of these two are communicating.
And they can help each other.
That's not good care.
No,
that's not how we do good care.
Right.
And so there's a lot of that in medicine too. So creating a community of care providers would really help women.
Yes.
And then creating a community of women would help them feel validated, not so alone. They share experiences. Like, I learn from the women on my Facebook page.
Yes.
My Dead Lady Balls page. Like, someone will say, oh, this really helped with my whatever. And I'm like, oh, never heard of that. Looking it up. Right. And now I have another thing I can tell patients. So, like, it's a shared learning community.
Yes.
And for anybody on my Facebook page who might be listening, I haven't been very active on there lately because I've been trying to get back to work. So I will be back to making regular posts because I've got some courses coming up, like a perimenopausal survival course, one in person, one on Zoom, and some Zoom sessions that I want to do too. That because I know lots of people have questions, so that's going to be coming down the line at some point.
We're going to get on that. Your Facebook group that anybody can join is Dead Lady Balls on Facebook.
All one word. Dead Lady Balls.
One word. There's over 3,000 women in that group.
Yep.
And get in there because you are going to be more active in there.
Exactly. And you can post anonymously too, because that's the tough part for some women. Like, this is a small town. So you don't want to be like, hey, anybody else got an itchy vag? And then like everybody in Comox knows you have an itchy vagina. So you can post anonymously, and it's private. So you actually have to be a member to join. So
but it can be worldwide too. Worldwide.
Oh yeah, totally.
Anybody can access this.
There's people from all over the place in there.
Yes. One last thing I want to kind of wrap it up with is we also talked about, you want people to do their homework.
Mm-hmm.
But that's another thing that you've got kind of going on, is they need to know what homework to do.
Exactly.
Right? So
that's an important point.
It is. I really like that, because it's like, and wasting time is not the right word, is to get the most value out of the time that you have.
Exactly.
If you do these things first and then come to me,
exactly.
We can make so much more progress.
Yeah. One of my patients told me she had gone on YouTube and watched a couple of videos I had posted there from my Facebook page. And she was like, you should tell all your patients to watch this before they talk to you. And I'm like,
exactly.
Actually, I am doing videos for patients, and we're going to send them the links. I just haven't done it yet. But that pre-education, because I don't have time to explain menopause to every single patient.
Right.
And in all fairness, if I have to do that 12 times a day by the end of the day, I want to put my head through a wall. So I'd rather say it once to a bunch of people than individually. So, and there's no time. So that sort of thing. And that kind of segues too into, speaking of lifting your end of the sofa, it's keeping track of your symptoms. So if like, say you're getting ready to go see your doctor to ask about hormones, and you have some trepidation, like, oh, they're going to say, you're too young or whatever. And especially if you have a doctor who has the one issue per appointment policy, which I understand why they do it.
Right.
But if you're going through perimenopause, you might as well call them and say, I'm in perimenopause. Can I book 36 appointments, please? Because there's not just one issue. So if you can prepare by, and this is especially relevant for women in perimenopause, where their symptoms are on again, off again, your hormones are all over the place and you don't know up from down.
Yes.
If you can even take a cycle and keep a journal and write how you sleep, your mood, your energy, were you warm? Did you have a headache? Were your breasts sore? Anything else you've noticed? And write it out every single day for a month. You will see patterns.
Yes.
And then you can actually go to your doctor and go, but look at how I am feeling all month long. And when you actually have data and you're like, I've kept track of this for a month, this is the impact it is having on my life, then it's harder for your doctor to not deal with it than if you just go in and go, I don't know, I'm feeling kind of weird. Like, could it be my hormones? Could I be in menopause? Can I have my hormones tested?
Yes.
The answer is going to be no, you're not getting your hormones tested. There is no test for perimenopause. It's not, I don't need to test hormones. I just need to talk to you.
Yes.
Women who are way too young or something weird is happening, sure. But for the most part, you don't need to test somebody to see if they're in menopause, for goodness sake. They'll tell you if you listen to them, right? Yeah.
So true.
So that's a really good way to prepare for the conversation with your doctor. It shows them that you're concerned about these symptoms. It shows them that you're invested in your care because you have taken the time to take the journal.
Absolutely.
And it's a lot harder to dismiss somebody who's put in that effort. And then you need to continue doing that when you start on hormones, so that you can really look back and gauge how they are affecting you. Because come on, do you remember what you did last week?
No.
In all clarity, you remember how you slept last Tuesday night? No, I don't either.
No.
So
I don't remember what I ate yesterday.
Write it down. Write it down.
Yes.
And that's part of like making a commitment to yourself.
To you.
And it's the same thing like the inside work. Like if you don't exercise and you drink too much and your diet's not great and you're like, well, why don't I feel amazing on hormones? Like, hormones aren't going to fix that. Like, you actually have to do stuff for yourself. So I can do the outside work with you, but lifting the end of the sofa is you need to do your inside work. And I can say firsthand, that's easier said than done. So some of us need guidance and support to get there. I know I do. I struggle with it a lot, which is why my brain goes right to support group, community. Let's all do it together, because there's accountability in that too. Like if you can't be accountable to yourself, practice first by being accountable with other people.
Yes.
And eventually you'll get better at trusting yourself to do the thing you say you're going to do.
Yeah. And we're worth it. We're worth it.
Yeah, totally.
I mean, it's worth the time that you're going to put into yourself. It's going to change everything. And moving forward in your health journey. I mean, we're in it, right?
Exactly.
But we need to be the ones to advocate for ourselves and have the, like you said, have that evidence to show, no, this is actually what's happening. I mean, that helps them do their job too. You're giving them more information.
You're making it easier for your doctor who's got like seriously like 6 or 7 minutes to spend with you.
So whatever we can do for them.
The other important point we should throw in there before we finish is age. So if you are in your late 30s and you get told you're too young to be in perimenopause, you're not. Not a lot of women are perimenopausal that young, but if you look at the earliest normal age to be in menopause is 40 to 45, depending on where you read. And the average age is 51. Most women are in perimenopause for 5 to 8 years. So if you're like me and you're going through menopause in your early 40s, you're in perimenopause in your 30s. And a lot of 30-year-olds don't clue into that. And they probably don't want to hear it either. Like, you know, that sucks. It sucks. Like Baroness on Sketch, but I'm wearing a jean jacket, but I own a snowboard. Like, this can't be happening.
Exactly.
But it is.
Exactly.
But those women often don't get taken seriously, right?
Yeah, that's right. But I think it's these types of conversations that are going to make this just a normal topic of discussion. And there's not going to be that shame around it. I know, like everybody should be talking about this. And it's because I experienced that when I was going through it.
Yeah, exactly.
And it was like, we gotta, why isn't everybody talking about this? And now it seems like a lot more. I mean, you must have seen that, right? It's a lot more. People are willing to share what they're going through, what's happening, and their experience with whether they tried HRT or HT, I don't know.
And it's the social media trend towards talking about menopause is, again, another double-edged sword, because it's more good than bad, because the good is we're getting the word out there and people are actually going, wait a minute, maybe okay. And so the more information people have, the more awareness, the more normal it is to talk about. That's all great. But it also opens up an avenue for people on there who don't actually know what they're talking about. So the problem is you've got people trying to make a buck and sell things to vulnerable women who are desperate for help, who aren't getting it from their doctor. So I sort of like, on the one hand, you've got the Gwyneth Paltrows who are telling you to shove jade eggs up your vagina. And, you know, doctors are very critical of the Gwyneth Paltrows, but we actually created them. You think she could get away with that if doctors were doing their job and giving exemplary medical care? No, nobody would listen to Suzanne Summers or Gwyneth Paltrow. But when women are desperate and they're not getting the help they need,
and somebody's out there.
Exactly. So I sort of worry sometimes when you do complementary and alternative things, and I work with naturopaths, I listen to Chinese medicine doctors, I went to an energy healer when I was getting better. Like, I'm getting more woo-woo than I ever thought I would.
I love it.
I worry about getting lumped in with the Gwyneth Paltrows, but I'm like, no, it isn't like you're either a quack or you're an MD. There's an in-between, right? And by the way, not everybody on this side of the fence knows what they're doing either. So like, you know, the truth is often somewhere right in the middle. And because it involves your whole body, sometimes it takes a village, and you've got to go where you need to go to get the answers you need. But it's also buyer beware a little bit. So, you know, if you're getting your information from people, like you get some from the North American Menopause Society, some from people like Marie Claire Haver, Jen Gunter, from me. And, you know, if somebody is just an influencer who has no education in menopause or hormone health, you got to take it with a grain of salt. But I'd be listening to a woman who's done personal training and fitness stuff about how to lose weight and get in shape more than I'd be listening to my doctor.
Right.
So,
Yeah.
you've got to have a good filter,
Yes.
but be open to the fact that there's lots of different lenses that you can view this through and lots of different avenues to get help.
Yes.
Right?
Yes.
Yeah.
Absolutely. I think that's a perfect way to wrap it up.
Exactly. I so appreciate you pushing to get the word out about menopause. And I can take referrals from anywhere in the province. Right now, I don't have a long wait list, but I am going to keep it that way. So if I get too full, I'm going to close off to referrals because I do not want women waiting 6 months to see me to get relief. That's not okay.
Yeah.
And I can only do so much of it. But as I offer groups and other things, there's other ways for people to get information and then they can ask somebody else to prescribe. Like that's the thing. You can know what you need, but getting somebody to actually prescribe it is a bit of a challenge at times, right?
Exactly.
Yeah,
That's why we need more people like you. But
exactly.
You start getting out there in groups, it's just gonna get out to more people. So
it'll happen.
They just want somewhere to land. They want somewhere to go, So you know how much I love what you do and what you bring. And I know that your intention is just that's what you're passionate about is helping women because they don't need to suffer.
And right back at you because you do the same thing, right?
Thank you.
You do the same thing.
Yeah.
And the work you do is such a beautiful complement to the work that I do, because that's what I mean about whole care. Like you take care of women's souls. Like you take care of their soul and I help them take care of their hormones. So, and it goes together so beautifully, right? Like it's hard to have, hard to have good menopause care without the soul work too. So
I agree.
I see more collaboration in our future, darling.
Yes. I think you need to do a chapter in the next book.
Yep, I definitely
Before you write your whole book. How about a chapter?
Yeah,
a chapter.
Exactly. I will give you a chapter for sure.
I love it. Well, thank you so much. And
have a wonderful evening.
Stay on there for 1 second.
I sure will.
Thanks, everybody.